let's wrap up with a little bit of a conversation about the future. Are there new drugs that you're excited about? Are there new combinations you're excited about? Where do you think we're headed from here?
Yeah, I mean, so yes, I think that we've gotten a lot of new exciting medicines with trastuzumab deruxtecan and tecotinib in the metastatic space. And so I'm excited to see those move forward down the pipeline. I think we still have a lot of questions about sequencing now that we have, again, you called it earlier, it's a celebration of riches. We've got so many agents now trying to figure out who to sequence, particularly given the unique trial design of tecotinib for patients with brain mets. I think one of the questions that most of us have is, should we be prioritizing tecotinib over other HER2-directed therapy for patients specifically with brain disease? And it's not to say that the other agents don't work for patients with brain metastasis, but with such clear data in the tecotinib space, it's hard to ignore that. And so I think that sequencing is one of the big future directions. I think that looking at continued attempts to combine HER2-directed therapy to eliminate the chemotherapy backbone. And so one of the trials that both of us are involved in is looking at TDM1 in combination with some of these newer agents, tecotinib specifically, which would eliminate the role of capecitabine in combination with tecotinib, combining it with an antibody drug conjugate, which might be a nice option with a more favorable toxicity profile for patients.
Yeah, absolutely. I completely echo that. Another question I have about tucatinib is whether we used it early, whether we could prevent some brain metastases instead of being, reactionary, be a little forward thinking, with up to 50% of patients with metastatic disease eventually getting brain metastases. I think that's a really important question to ask as well. I think
Yeah.
trastuzumab deruxtecan will very likely be moved up into the earlier settings as well. As far as new agents, I have the privilege of working within our phase 1 unit, so I get to see some of the new things that are coming across the table as well. I'm pretty interested in the bispecifics, and bispecifics come in a couple different flavors. We certainly have the bispecifics that bind not only the trastuzumab binding site, but also the pertuzumab binding site, or even a novel binding site on HER2. I think kind of packaging that all in one is an attractive strategy. We also have ones that are bispecifics that are also antibody drug conjugates, so adding another little layer to it. And then finally, we have bispecifics that bind HER2 on one side and then have an antibody that engages the immune system on another. So really a different way to think about so-called immunotherapy, or how can we bring the immune system in to engage with these HER2 positive cells. And so I think, for a new class of agents, those are some things that are coming. For these patients that have HER2 positive metastatic cancer and are very HER2 driven, they live for a very long time, and they get benefit out of each HER2 agent that we give to them. And I think as we see some of these agents that are very effective, such as TDM1, such as pertuzumab, being moved into the earlier setting, it really does open up the stage to the fact that we still need new therapies for metastatic disease as well.
Yeah, and I mean, other future directions, we're now seeing early endeavors using CAR T in HER2 positive disease, which is exciting for those patients. And then, we've been focusing on sort of the traditional definition of HER2 positivity, but we've got drugs like MCLA-128 that are expanding those definitions. So we have trials looking at that HER2 low population, somebody who is HER2 1 plus, but not FISH amplified, HER2 2 plus and not FISH amplified, to figure out if there are some patients that respond to these targeted approaches that don't meet the traditional definitions of HER2 positivity. And I think that that's another direction to continue to explore.
Absolutely, and we've seen good data from trastuzumab deruxtecan in that space. With it being an antibody drug conjugate and having a bystander effect, the response rates in the HER2 low were really quite impressive. And I think if we think about the small percentage of patients that are truly HER2 amplified, the percentage of patients that would be classified as HER2 low is even broader. So potentially a large amount of people we could impact there.
Yeah.
Anything else you want to say wrapping up, or last words of wisdom or things to think about?
Yeah, I mean, I think my closing sentence would be what my closing sentence often is, which is everything we just talked about, all of the advances we made were because patients enrolled in clinical trials. And that means that we as clinicians have to be considering what's out there for our patients, referring and recruiting to clinical trials as much as possible so that we can continue to celebrate these 11%, you know, 18-month improvements that we're talking about, which is really, really exciting. And even more so, all of these advances were made because patients volunteered to participate. And so I can't celebrate the contribution that patients make in advancing science enough. I mean, they are the unsung heroes of every single thing we've ever achieved. And I'm thankful for them.
Yeah, absolutely. I completely echo that. I'm always amazed by our patients and what they're willing to do. I think we have a responsibility on that end as well, and to make sure that we offer the patients the clinical trials, and also that we start really critically looking at some of these clinical trials and how to broaden eligibility criteria. We certainly want therapies to be safe for our patients and the right patients to be going on the right trials, but sometimes these are a little bit artificially restrictive. And I think, broadening those. The HER2 climb trial with tucatinib was a great, first step. We saw an inclusion of a population of patients that typically would not have been allowed on clinical trial there. They were brain metastases, patients that had brain metastases that were not only stable and treated, but two other categories: patients that had asymptomatic untreated brain metastases, and patients that had treated and subsequently progressive brain metastases. So things like that, things like maybe creatinine clearance or baseline blood counts, et cetera, for drugs that we don't really think that affect those. I think chronic infections like HIV, hepatitis C and B, et cetera, are some of the opportunities we can really broaden to allow more people to participate on trials.
Yeah.
So thank you so much for having this conversation. I've really enjoyed it. Thanks to our audience for watching this targeted oncology presentation on precision medicine, and we hope you found this discussion to be useful and informative. We certainly enjoyed it. Thank you.
Yeah. Thanks.